Welcome to the Deep Dive. We sift through the sources so you don't have to. Today, we're diving into something huge. How we try to make healthcare systems work better.
Right. And for a long time, the main guide, the framework everyone looked to, was this thing called the triple aim.
Exactly, the triple aim.
Okay.
Okay, let's unpack this a bit. It had three big goals. Better population health, making the patient's experience better, and lowering the cost per person.
Seems logical, right? Improve health, improve experience, save money.
Totally. Sounds pretty solid. But, despite having this clear map, a really big problem started cropping up, something that actually threatened to derail the whole thing.
And that's exactly what our sources for today's deep dive get into. We're looking at this major challenge and how it led to a proposed evolution of the triple aim.
So what are we drawing on today?
We're mainly pulling from some really key articles. There's one from the Annals of Family Medicine back in 2014 and another from BMJ Quality and Safety in 2015. And our mission really is to figure out why this big shift was needed, why the original wasn't quite enough, and what that means for how healthcare actually works.
Okay, so let's lay that foundation first. The triple aim: improving population health, enhancing patient experience, reducing costs. It really took off, didn't it?
Oh, absolutely. It became like the global standard pretty quickly. It shaped a lot of redesign efforts, especially moving towards thinking about the health of whole populations.
So those three dimensions were the core.
They were. And what's interesting, and maybe not always obvious, is that while all three are important, the main goal, the ultimate aim of the triple aim, was actually improving population health.
Okay. So the other two, patient experience and cost, they were sort of supporting that bigger goal.
Exactly. They're crucial means to that end. You need good experiences and manageable costs to achieve broad population health. It's all interconnected. It's quite fascinating how quickly it just became foundational.
Foundational, yeah. But then came the twist. Even with this framework in place, we started hearing about this massive problem, burnout, widespread burnout, and just deep dissatisfaction among healthcare professionals.
Yeah, the people who are supposed to make the triple aim happen.
Right. And the things you hear from them, they're gut-wrenching. Quotes like, "The joy of practicing medicine is gone," or "I hate being a doctor, I can't wait to get out."
It's stark. And that one quote really hits hard. "I am no longer a physician, but the data manager, data entry clerk, and steno girl. I became a doctor to take care of patients. I have become the typist."
Wow. That says so much about the frustration. It's not just feeling tired, it's feeling like your purpose has been stripped away.
And the numbers, well, they paint a pretty grim picture, too. It wasn't just a few unhappy people. We're talking nearly half, 46% of U.S. physicians reporting burnout symptoms.
Almost half. That's huge.
It is. And it was even worse in some areas like emergency medicine, general internal medicine, neurology, family medicine. Those frontline specialties were hit really hard.
And that stat about regret.
Oh, that one's staggering. A 2014 survey found 68% of family physicians and 73%, nearly three-quarters of general internists, said they wouldn't choose the same specialty if they could do it over.
73%. That's more than just burnout. That's a crisis of professional identity, isn't it?
It really is. And another survey in 2015 found 60% of U.S. physicians were thinking about leaving practice, and 70% knew colleagues who had left because morale was so low.
So it's affecting retention, the workforce pipeline, the whole structure.
Yeah.
And I assume this wasn't just limited to doctors.
Not at all. That's a crucial point. The sources are clear. This ripples through the entire care team. You see high burnout rates in nurses, too, like 34% in hospitals, 37% in nursing homes.
Still incredibly high numbers.
Right. And think about this. A 2013 survey of RNs found over half worried their job was hurting their own health, and more than a third felt like quitting.
Wow.
Even the receptionists, for first people patients often interact with, they face immense stress. One study found 68% experience verbal abuse from patients.
So it's systemic. It's hitting everyone involved in delivering care. Which leads to the big question, right? What on earth was causing this? What's driving this feeling of, defeat?
Well, the sources point to a few key things. A big one is this widening gap between what society expects from doctors, always available, empathetic, knowing your whole history, and the actual time and resources they have to deliver that.
So expectations are going up, but support isn't keeping pace.
Pretty much. And interestingly, a major source of physician dissatisfaction wasn't necessarily difficult patients, but the feeling of being unable to provide the quality care they want to give. The system itself felt like a barrier.
The system itself, okay, that's important. It's not blaming individuals, but looking at the structures.
Exactly. And what's one of the biggest structural barriers they named? Paperwork and administration. Just Overwhelming amounts of it.
I've heard about that.
Get this, 87% of physicians called it the top cause of stress and burnout. And almost half, 43%, said they spend over 30% of their day just on admin tasks.
More than 30%.
Woo!
Not on patients.
Often, yes. They spend more time on things around patient care letters, managing the inbox, prescription refills, than actual face-to-face time.
That fundamentally changes the job, doesn't it?
It does. And even when they are with the patient, in the exam room, primary care docs might spend like 25 to 50% of that time looking at the computer screen, dealing with the electronic health record, the EHR.
Ah, the EHRs. They were meant to help, right?
That was the idea. But for many, they've actually made things worse in terms of satisfaction. All the data entry takes time. It can feel clunky, and it interferes with just, talking to the patient.
So it becomes a barrier to connection.
It can, yeah. Take emergency medicine docs. One study found they spend 34% of their day just on data entry. They perform something like 4,000 EHR clicks per shift.
4,000 clicks in one shift.
4,000 clicks, and only about 28% of their time is actually spent with patients.
That's just mind-boggling. You can see how that leads to feeling like a data entry clerk.
Absolutely. And then there's the flood of electronic alerts and messages like inbox notifications, test results, requests. Primary care docs in the VA system were spending nearly 50 minutes a day just managing these.
50 minutes just on alerts.
Yep. And often, many of those alerts weren't even clinically significant or could have been handled by someone else. It's constant interruption, which we know isn't good for focus or patient safety.
Right, those interruptions can lead to errors.
They can. Plus, the work environment itself can be tough. Healthcare actually has higher rates of workforce injuries than you might think, higher than mining or construction in some cases.
Really? What kind of injuries?
It includes physical things, but also psychological harm. We're talking about bullying, intimidation, sometimes even physical assault from patients or families. Lack of respect, intense production pressure, badly designed workflows, lots of work that doesn't really add value. It all adds up.
That sounds incredibly stressful beyond just the workload.
It is. And layered on top of all this is a bigger gradual shift that the sources mention, healthcare moving from being seen primarily as a public service towards more of a business model.
The business side.
Yeah, which can mean more focus on productivity, efficiency, throughput, sometimes reducing complex human interactions to sort of transactional tasks. And this is often driven by pressures like decreasing reimbursement rates.
Okay, so we have this perfect storm. System barriers, administrative burden, EHR frustrations, a stressful environment, and this shift towards a business mentality. So what does this actually do to patient care? How does the provider burnout crisis threaten the original AAA goals?
It threatens them directly. The connection is really clear. First, patient experience. Dissatisfied doctors and nurses. That's linked directly to lower patient satisfaction scores. Makes sense, right?
Yeah, if your caregiver is stressed and unhappy, it's hard for them to provide that positive experience.
Exactly. Then, costs. Burnout can actually increase costs. Think about turnover. Replacing a family physician who leaves due to burnout can cost almost $250,000.
$250,000 just for one doctor leaving.
Roughly, yeah. When you factor in recruitment, training, lost productivity, it's a huge expense. Plus, some studies suggest dissatisfied physicians might overuse resources or prescribe inappropriate medications more often.
Wow. Okay. So it hits costs and potentially quality.
Definitely quality and safety. Burnout is linked to things like lower empathy and reduced adherence to treatment plans by patients, which obviously affects outcomes. And patient safety is a big one. Nurses, for example, report that high workload sometimes cause them to miss important changes in a patient's condition.
That's terrifying.
It is. And finally, population health. Burnout makes the existing shortage of primary care physicians even worse. If doctors are leaving or cutting back hours, it's much harder to achieve broad access to care and improve the health of the whole population.
So it undermines all three pillars of the triple aim.
Precisely. And here's the really tricky part, the paradox you mentioned earlier.
Right, the idea that trying to achieve the triple aim could make things worse.
Yeah, it sounds counterintuitive, but some studies found that practices scoring higher on things like the patient-centered medical home model or those using more EHR features like patient portals or electronic prescribing. These practices sometimes had higher rates of clinician burnout.
So the very tools and models designed to improve care were adding to the burden.
In some cases, yes. It seems the implementation, the added workload, wasn't always balanced with enough support. There's a really powerful example from Group Health Cooperative that the sources highlight.
What happened there?
Well, they initially rolled out primary care reforms, specifically aiming for triple aim improvements, but the result, physician burnout actually increased, and consequently, quality went down and costs went up. It completely backfired.
Oh, wow. So what did they do?
They changed course. Around 2006, they pivoted. They decided to focus first on improving the work life of their clinicians, things like increasing visit times, reducing the number of patients each doctor was responsible for.
They put the provider first.
They prioritized the provider experience as a prerequisite. And what happened? Burnout dropped significantly. And then they saw major gains in clinical quality, patient experience, and cost reduction. It was a total turnaround driven by focusing on the care team's well-being.
That's a fantastic case study. It really drives home the point. Maybe you can't achieve the triple aim without addressing the people delivering the care.
That's exactly the conclusion the sources reach.
Which leads us to the big proposal, right?
Yeah.
If caring for the patient requires caring for the provider, how do we make that official? How do we build it into the system?
The proposal is to evolve the framework, to move from the triple aim to the quadruple aim.
Adding a fourth dimension.
Yes, adding a fourth goal. Improving the work life of healthcare providers, including clinicians and staff, recognizing that this is just as critical as the original three.
Improving work life. What does that really mean in this context? Is it just about, like, less stress?
It's deeper than just reducing stress, though that's part of it. The sources talk about restoring meaning in work, which isn't just about being happy, but about feeling a sense of accomplishment, feeling like your daily work is important, feeling successful and fulfilled.
Okay, so purpose and accomplishment, not just lack of negatives.
Right. The idea is that an engaged, thriving workforce is the absolute backbone. You can't have a high-performing healthcare system without it.
Makes sense.
But there's a crucial foundation needed even before you get to meaning and fulfillment, and that's ensuring the workforce is physically and psychologically safe. Freedom from harm, from neglect, from disrespect, that have to be non-negotiable.
Safety first. Physical and psychological.
Absolutely. It ties into core values.
Okay.
Respect, civility, transparency, honesty, safety. Organizations need to actively foster these and regularly recognize the contributions of their people.
So it's about culture, fundamentally.
It is. Paul O'Neill, the former CEO of Alcoa, who famously focused on worker safety, had these 3 questions he believed every worker should be able to answer yes to every day.
What were they?
First, am I treated with dignity and respect by everyone, every day, without regard to background, title, or pay grade? Second, do I have the education, training, tools, financial support, and encouragement I need to make a contribution that gives meaning to my life?
Okay. Dignity, respect, resources, meaning.
And third, am I recognized and thanked for what I do?
Recognition. Simple but powerful.
Incredibly. And O'Neill argued, and the sources echo this, that if people can't answer yes to those questions, the organization simply cannot reach its full potential for safety, for quality, for efficiency. So this fourth aim, it's not just like an extra nice to have. It's foundational for the other 3 to even be possible.
Right. It becomes the bedrock upon which the other aims can be built.
Okay.
So if we accept this quadruple aim idea, let's get practical. What are some concrete steps, some actionable things organizations can actually do to work towards this fourth aim?
Yeah, the sources offer some very specific strategies, particularly looking at primary care. One big one is implementing team documentation.
Team documentation. What's that?
Basically, having nurses, medical assistants, or other staff in the room during the visit who can help enter information into the EHR, handle order entry, process prescriptions, maybe even assist with billing guides.
So freeing up the doctor from some of that EHR burden we talked about.
Exactly. It distributes the load. And studies have shown this can lead to higher satisfaction for both doctors and staff. It can improve practice revenue, allow for slightly larger patient panels, and maybe even let people go home on time more often.
That sounds like a win-win. What else?
Other things include using pre-visit planning, getting things ready before the patient arrives, and doing lab tests before the appointment, not after. That cuts down on time spent chasing results later.
Makes sense. Be proactive.
Right. Also, expanding the roles of nurses and medical assistants, letting them take more responsibility for things like preventive care screenings or chronic disease coaching, working under protocols set by the physician.
Empowering the whole team.
Yes. And standardizing workflows for common tasks like prescription refills. One approach they mentioned could save doctors up to 5 hours a week while actually providing better, more consistent care.
5 hours a week just from standardizing refills.
Mhm.
That's significant.
It adds up. Even simple environmental things like co-locating teams, having the doctor, nurse, and MA working physically close together has been shown to boost efficiency, maybe saving 30 minutes of doctor time per day just through easier communication.
Little changes, big impact.
Potentially, yeah. But there's a really important caveat here.
Okay, what's the catch?
You have to be careful how you implement these changes. You don't want to just shift the burnout from the doctors onto the nurses or MAs.
Good point.
So any staff taking on new roles need proper training. They need to understand why their work matters for patient health. And crucially, practices need to actively look for unnecessary work, redundant tasks, and just get rid of them. Re-engineer the process. Don't just redistribute bad work.
Streamline.
Right?
Don't
Yeah.
just shuffle.
Exactly. And looking longer term, the sources acknowledge that many of these solutions ultimately need more resources, more funding, more staff dedicated to primary care to really bridge that gap between expectations and capacity we talked about earlier.
Right, the systemic resource issue.
Yeah, one study estimated that to fully implement that patient-centered medical home model, primary care practices might need almost a 60% increase in staffing levels, something like 4.25 staff members for every physician.
Wow, that's a major investment needed system-wide. Okay, so these are the kinds of changes needed. But how do we know if any of this is actually working? How do organizations measure progress on this fourth aim?
That's key, right? You need to track it. The sources suggest focusing on a few main areas for measurement. First, workforce engagement.
Engagement, okay. How do you measure that?
Usually through things like annual employee surveys. There are established tools and frameworks you can use, which also lets you benchmark your results against other healthcare organizations and even against other industries.
See how you stack up.
Right. Second, you need to measure the opposite, workforce burnout. Again, there are validated instruments like the Maslach burnout inventory or maybe select questions from it, which is kind of the gold standard for assessing burnout.
So track both the positive engagement and the negative burnout.
Exactly. And third, workforce safety. Remember that physical and psychological safety piece. Metrics here should include tracking things like work-related deaths or serious disability, injuries that result in lost work time, any injuries that have to be reported to government agencies, and ideally, all injuries, even minor ones.
Really comprehensive safety tracking.
It needs to be. Now, the sources acknowledge that these metrics, engagement, burnout, safety stats, they don't capture the entire nuanced experience of providing care, of course not, but they provide a practical starting point, a way to get a baseline, see where you are, and track if the changes you're making are actually improving things over time.
Got it. So measure what you can, track it, and use it to guide improvement. Okay, so wrapping this up, the core message seems crystal clear. This quadruple aim isn't just a nice idea or an optional add-on. It's being presented as a fundamental requirement for a high-functioning healthcare system.
Absolutely. It's foundational. And the sources really emphasize that leadership has a parallel moral obligation here. Just as they have an obligation to patients, they have one to their workforce to create an environment where people can find joy and meaning in their work.
A moral obligation. That's strong language.
It is, because if you connect it all back, achieving this quadruple aim, taking care of the caregivers, it isn't just about making staff happier, though that's important. It's presented as the key to unlocking the full potential of the system to actually save more lives, reduce suffering, and deliver the kind of high-value care the triple aim originally envisioned, but maybe couldn't fully achieve on its own. It could be on an audacious scale.
That's a really powerful vision. And it leaves us with something interesting to think about, doesn't it? You mentioned that shift, that drift maybe in healthcare from being primarily a public service toward more of a business model.
Right, that underlying tension.
So here's a thought for you, the listener. If we really embrace this idea of fostering meaning in work for healthcare providers, how might that fundamentally reshape healthcare's identity? Could it push back against that purely business focus? What new possibilities open up when caring for the provider becomes truly integral to caring for the patient, not just an afterthought or a means to an end?
Yeah, what does healthcare look like when the well-being and purpose of its workforce are truly at its core?
Something to mull over. We hope this deep dive gave you some valuable insights and maybe sparked some new questions for you.